It's just a huge honor for me today to be podcast interviewing Dr. Gian Pietro Schincaglia, DDS, PhD. He received his dental degree from the University of Ferrara, Italy, which I assume is why he drives a red Ferrari, and the Periodontal Certificate from the University of Southern California, Los Angeles. Since 2003, he is a Diplomate of the American Board of Periodontology, and in 2006, he received his PhD degree in bone biology from the University of Ferrara. From 2007 to 2014, he was Associate Professor in Periodontology and Director of Graduate Program at the University of Connecticut, and is now Chair and Postgraduate Program Director of the Department of Periodontology at West Virginia University. He has been published extensively in peer-reviewed journals. His research activity is focused on implant, immediate loading, peri-implant mucositis, periodontal regeneration, and bone graft. And Gian, I cannot tell you what an honor it is to have you come on the show. I know you're busier than a one-armed dentist. Thank you so much for coming on the show today. How are you doing?
Very good, very good. Thank you, Howard, for having me. This is my first podcast in my life, so that's going to be a very interesting experience. And I look like you're on fire, so I'll try to warm up too.
Well, I'll tell you what, it can only go up. You're starting with the worst dental podcast on the internet, so it can only get better from this one on out. But I have to, I want to start out first, since you have two doctorates that everyone wants to know, would you take the vaccine today?
Yes, of course. Actually, part of my doctorate project was to work on a early application of the liposome transfection using DNA. At the time, we were looking at some methodology to modify the expression of bone cells to produce more bone if in case of osteoporosis. That was an in vitro study because for many, many years, the use of liposome technology was forbidden and it was just limited for very few conditions. And this, I think, is going to be a breakthrough of science. And this is, if something good this year brought to us, which is very limited amount, is probably this breakthrough through technology and science. And you can see the same technology is applied to cancer now, and you may develop vaccine for cancer using this platform.
Well, who cares about cancer? I want to know about hair loss. Are they going to be able to grow my hair?
Me too. We are in the same boat.
Oh my gosh. Well, I remember the good news when I was a freshman at Creighton. The big news on TV was that Upjohn Pharmaceuticals in Kalamazoo, Michigan, cured male pattern baldness with minoxidil drops. And so I bought my drops, and it was so much money, and I'm pretty sure it didn't work. So I don't know. I don't get my hopes up too easy anymore. You know, I want to start out. You know, we have so many kids watching this show. A quarter of them are in dental school. I know you're in the postgrad program, so you get to in perio. So, but you get to see the undergrads. You know, those kids. You know, when I got out of school, there were 8 specialties. There was, and now there's 12. And you know, you are talking about implantology, bone grafting. A lot of people say, we had oral surgery, endodontics, perio, pediatric, ortho, pros, dental anesthesia, and now they've added oral facial pain, oral med, oral path, oral radiology, and I forgot the dental public health. A lot of people were saying that it should have been implants. Implantology should have been a specialist. It seems kind of divided between oral surgery, perio. What would you say to people who say, well, because that's what you do. I mean, you're an implant specialist. I mean, you got 2 doctorates. You're on implants, immediate loading, peri-implant, mucositis, periodontal regeneration, bone biology. How do you distinguish between oral surgeon, periodontist, and implantologist?
Well, implant dentistry is a cross-sectional type of specialty that is mainly a restorative discipline. With the extension of the surgical component. So is multidisciplinary. I have no problem to have a prosthodontist or other specialties encroaching with implants. Of course, you need to have a broader view of the discipline is not just surgery, is not just restorative, it's a combination. So perio for many years has been basically working with pros before implant in restoring and recuperating teeth for fixed restoration, right? And that's what probably led to perio to be closer to in communication and collaboration with the PROSFA group. That's what happened here at WVU. We have a great collaboration between the two departments that is generating research and new approaches and new technology and the use of full digital workflow. For each one in the game, the important thing is to have a comprehensive understanding of oral health. And of course, I have to push a little bit toward my side. Perio is the only specialty that includes also in the board certification in periodontics and dental implant surgery. So we're a little bit ahead of the game in terms of qualification, if you will. Other than that, I think is everybody's game. There's no specialty is better than the other. Of course, the scope of practice of oral surgery is broader. They can work on more severe atrophic edentulous sites and full arch rehabilitation. But for perio is more toward aesthetic and detailing. So it's like, working on different metrics sometimes.
Well, your dean, I love your dean, Photo. His real name is Photinos S. Panagagos. How do you say that? I know it's Greek.
Panagakos. Yeah, we have always have a debate between Italians and Greeks. So,
well, I'll tell you what he's going to do. Did you ever see that movie, My Big Fat Greek Wedding?
Yeah.
He's going to try to go to the prosto department and have everybody spray Windex on the inside of the crown so they see it easier. That's the Greeks' most famous trick. My gosh, but I want to I just want to point out to the kids before I get into this that, I love it when I hear you and you come out of school and you're bright-eyed and bushy-tailed and you tell me you want to learn oral surgery and root canals and perio and silver diamine fluoride, and you want to learn orthodontics, Invisalign. You want to learn all these things, but I mean, look at this guy. I mean, my gosh, it's all coming down. Especially, to place an implant, you got to know about implants, immediate loading, peri-implant mucositis, periodontal regeneration, bone biology. My gosh, kids. My advice is that you come out of school and you spend 10,000 hours, which will take you about 10 years, to become the very best in one thing. And if you think you're going to be the best in 12 different specialties,
No.
you're going to have to live to be at least 200 years old. My gosh. So I love your enthusiasm, but you got to focus, because I walked away from implants. I have my Diplomate in the International Congress of Implantology. I got my fellowship in the missions too, but I got it when the new CBCT of the day back in 1987 was when they did that software upgrade, so the pano would show an R on one side and an L on the other. And that was the greatest radiographic invention of all time. And all the people who taught me implantology were doing it with a pano. There was no 3D. And what got me out of it was that I realized just for me to understand the bone grafting around it was going to be another 80 gazillion hours of continuing education. And I thought, you know what? There's oral surgeons and periodontists up the street. It's just too much. You can't master 12 specialties. So the reason I'm going to get back into placing implants, because I know we're just like 2 days away where I can sit in my jacuzzi drinking a beer and my Yomi robot will place the implant. Do I even have to get out of the jacuzzi and put down my beer, or will Yomi do it all?
Yeah.
I'm going to have to do that. Well, that's bad news.
You have to do it. I think that the robotics is the future. The reason why I push, and I had the great support of Fotinos here and the previous dean, Dr. Borgia, I have to give him credit. They were very supportive to include this technology here at WVU. I think the digital workflow and everything is going to be digital. You said starting from podcasting and a phone. It's not going to be a replacement of us as a professional. It's going to just improve the quality and the precision. The plan for the Yomi is also to include algorithm for crown prep and for root canal. So that's going to be, the futurable situation is going to be a lot of robots walking, being in practices to improve the quality of the treatment. Right now is not, the workflows needs improvement, although it's already improved a lot. But the precision, once the patient is connected to the machine, is incredible.
So, one of the dentists on Dental Town wrote, let's see what he wrote right here. He said, Dr. Paul Stadler, DDS, says West Virginia University School of Dentistry has become the second school in the nation to offer Yomi robotic guided implant surgeries under the guidance of yours truly. And he says, that makes me so proud as a WVU alumni to hear this happy news. What made you... like the vaccine, my 82-year-old mother's like, I'm gonna wait till everybody else takes it, see if it works. I'm like, Mom, you're 82. You don't have time to wait. There's 56 dental schools. How come you didn't sit there and say, yeah, let the first 10 or 12 try it? What made you want to be number 2 and jump on it early?
Because I want to be part of the development, and I have experience with research, and especially regarding implant immediate loading, and all this come very well together, as well as digital workflow. At WVU, we also have, like many other schools, we have our 3D printing system. The residents are trained on digital planning, on the software. They print out their guides. We print out the rendering of the jaws to do the regenerative, to make our own regenerative device. So it is a very exciting environment. That's what kids loves, and I hope I will be able to involve also the pre-doctoral group, and we are creating like a selective group of students that are interested in that. Unfortunately, COVID kind of destroy our plan for that education, but I think that that's going to be soon resumed, and it's all, I'm not saying this is the answer, but I rather, again, you have to embrace technology. You cannot push back. I heard a lot of colleagues say, oh yeah, but you can do that freehand faster. Yeah, that's true. I can do it. I can place an implant faster and without going through the setting up of the computer, of the robot. But the level of precision that I have with that is, you cannot compare to anything else at this point. We are under the sub-millimetric level compared to the guided surgeries is within 1 to 2 millimeters. So we are looking at a very sophisticated device. It needs a lot of work still in development, that's for sure. That's why we like to have it to be among the first one riding the wave, right?
And when you talk to the CEO of Yomi, the actual name of the company is Neosys, who makes the Yomi robot, and he's got a PhD just like you. Is he excited about the work level, the product? How would you say it's going? I mean, there's definitely dentists on Dental Town that have bought it and using it, and I got to ask them. I don't want to hurt your feelings or anything, but when lasers came out, my first laser, I bought it because it was a marketing thing. I mean, people were calling up my office saying, "Well, does he use lasers?" So you know what I did? It was 1987, and the Indy Yag laser just came out. It was $50,000. They sold 1,000 of them and then went out of business. And I wanted to buy one for marketing, but my friends were saying that it was too much money and it wasn't ready for prime time, and it eventually went to go bankrupt. So I went across the street to Radio Shack and I bought 4 laser pointers, which is a helium, and that way I couldn't lie. And I told my receptionist, if they ask how he has a laser, say he has one in every room, and they go, wow. And they would come in, and I had a laser in every room, but I wasn't going to drop 50 grand. And that was in 1987. That's like 100 grand today. But would you say that this Yomi is ready for prime time, or do you think you should buy a laser pointer instead from Radio Shack?
No, I mean, again, the concept, this is a very new technology, but it's not new. It's new for dentistry, it's not new in medicine. Remember that in in medicine, robotic surgery is almost everywhere, every specialty right now, thoracic surgery, orthopedic surgery, they use robotic technology. So it's nothing new. We just have, and actually, if you think about it, one of the areas that robotic can really be used everywhere is dentistry, because we need submillimetric precision, and that's what the robot can offer.
Well, I'll tell you what, I almost cried watching the news last night. That's how silly I am. But basically, long story short, there was a doctor treating a patient, and it got way over their head. But they could immediately went into telemedicine and got a experienced surgeon who just specialized on this rare thing 1,000 miles away, and she could watch and talk her through the surgery. So the surgeon's hands were listening to the experience. And anyway, this kid's life was saved from telemedicine.
Yeah, again, we have an amazing stage right now, and it can only get better. Just a question of putting. And regarding the Yomi right now, we have like about 64, 65 clinics in the U.S. that are using it. All type of specialty, both a lot of general dentists. We have, I know there are like oral surgeons, some periodontists, and again, the application is not fully exploited. I guess we start working on fully dental cases, but again, the algorithm, the technology is already there for like instead of going to recognizing the jaws using the CBCT scan like we're doing now. In a few years, there may be just a scanner, a photographic scanner, and and you can get expedite the process. Think about what happened with the guided system, with the intraoral scanners. All that is incorporated in this type of technology. So again, it's better to be part of it first, so you can evolve with that, and especially when I have to train and expose the younger generation.
Well, speaking of the younger generation, it's a lot easier to learn sine, cosine, and tangent while you're alone in a library than when you're with a patient in a retail setting. And that when the patients come in, they want those implants placed and immediate loaded right away. And I want to tell the young kids that you're the doctor, you're the dog, and you wag the tail, and the patient is the tail. But when you come out of school and you're a baby, you're 25, and you get some 60-year-old hyper-aggressive guy like me, and he's like, no, just do it this way, do it that way. And sometimes they talk you into doing things. And in fact, a lot of lawsuits I see with the young kids, the first thing I say is, oh, I knew I shouldn't have done this. I didn't want to do it. I told the patient I didn't want to do it, but he talked me into doing it. So I wanted, what's the lowdown on implant immediate loading? Obviously, they see the commercials on Clear Choice where they take a surgeon plus a prosthodontist plus a lab tech. They took 1 + 1 + 1. And I say it doesn't equal 3, it equals 5, because that's how many times that company's been bought and sold. It's been so lucrative. But implant immediate loading, when is it a good idea to immediate load, and when is it not a good idea?
I still that there is a lot of, as you said, a marketing use of this approach, and I don't think is a strategy that works for everyone. And we're still working on identifying the factors that are favorable for this technique. It's just a technique. We are not talking about a religion. It's a technique. It's like anything else. You have an instrument. You have, as you mentioned earlier, the laser. You may have. I mean, I'm training laser on the user laser, but I think has a very limited indications. I mean, and it's not going to change your life. Same as immediate loading. We have situation where immediate loading gives you an advantage, in particular, like in the aesthetic zone, when you have thick biotype and you want to have a better response on the soft tissue. Immediate loading, immediate provisionalization, immediate placement, immediate provisionalization seems to be good. We did some study where actually we showed that immediate application of loading reduced the remodeling of the bone around implants. Of course, that's improved the quality of life of the patient that doesn't have to stay in provisionals or denture for a long time. But yet, patient selection, planning, and execution become even more critical when you use immediate loading. And you have to be aware that you have a higher chance of having complications and failure.
So patient selection, planning, and what?
Execution.
And execution.
You have to be very precise. You have to make sure that stability of the implant is optimal. The prostheses have to be passive and well-balanced in occlusion. And all those parameters, as you said, a business model that uses immediate loading must have 4 specialists on board to execute.
And those 4 specialists be oral surgeon, periodontist, prosthodontist,
and lab techs.
And lab techs, okay. Yeah, and as far as you said, patient selection, planning, and execution, if you saw some of my implant surgeries, you would execute me. I am trying to get better at tooth extraction. That way I can just extract all my failed root canals, but my gosh, you said so many things. I want to say on laser just one thing. My goal is to try to get you in so much trouble. It's dentistry uncensored because I don't want to talk about anything that everyone agrees on. And I want to go after where the dentists are arguing hot. And when you said laser and you're a periodontist, what about that dental laser? There's a dental laser they're selling out there for $135,000. And some people just swear by it. And other people are like, that's a lot of money, doc. I just graduated $400,000 in student loans. What do you think of these Millennium Laser Periolace for $135,000? Is that you got 2 doctorates? What is your PhD?
Well, I'm used to buy on evidence. Okay, I strive to use my practice based on evidence. Now, when I talk to people that use Millennium Laser, and I have some of my former residents that have, because of marketing reason, they have to get the certificate to get hired in a practice. I'm not saying it doesn't work. It works, like modified Whitman flap or scaling root planing. That's what the literature shows. So you want to buy $130,000 scaler, is up to you. Now, there is a component that I think is important, is the patient-centered outcome. Patient-liked laser because it's less painful than the traditional surgery. So when you can have higher compliance on the patient coming back to do additional procedure. People that advocate the laser, especially the ND-YAG with the LENAP, lead to regeneration. They have to show me randomized controlled clinical trial to prove that. There's some anecdotal data, but you can then regenerate for anything. There's some study by my friend Nibali from the King College in London that shows 5 millimeter of bone regeneration vertical defect using just scaling and root planing. So it's just a tool as anything else, and you may have a location for that treatment, but we don't. What makes me a little nervous when we talk about the LENAP and LAPIP and all this type of treatment is that they haven't produced, despite they've been around for more than 20 years, they haven't produced one convincing study from independent researchers that shows that they are superior to other treatments. They are maybe equivalent, but the rest is
And kids, another thing I heard him say is, like you'll want to learn occlusion, and like Dentaltown has 400 online CE courses for like $36. That's not even the cab fare to the airport. But to learn something, you'll take a cab to the airport, you'll fly clear across the country, you'll stay in a resort, and you'll drop $3,000 on a weekend course, and then the next weekend I'll get you in a bar and we'll be drinking beers and having hamburgers, and I'll pull out a bar napkin and a pen. And I'll just say, "Tell me everything you learned." I mean, I'm ready to write. I can't even fill up a bar napkin, and they drop $3,000. It's like spend your money better. There's he just basically said that the Lanap was $135,000 scaler. Why don't you now? If it's a marketing thing, that's totally different. I
Yeah,
do know
yeah.
my podiatrist friend. He advertised all over laser foot surgery, and they come in, and he'd rather just use a scalpel in his deal, but he uses a laser. He says it takes some more time, it's slower, but so it's a big marketing thing for him. And so it's a multi-complex deal. Another thing the kids ask is are you implant agnostic, or is there a success reason of why I should pay more money for a premium implant, or some of these like look at Straumann? They own a very expensive Straumann, but they own the low cost Neodent out of Brazil. I mean, when should you spend money on premium, and when would the Southwest Airlines Value implant still get you to grandma's house in time for Christmas?
Yeah, well, that's a story that comes a long way. We always try to negotiate, quality versus costs, and there's no doubt that this more famous brand, they've investing a lot of money in research to improve quality, to improve outcome, and to research and development. That's expensive. I'm the one doing research on the other side, so I have to push that agenda. um, and the problem is, as long as we have a situation where the product has evidence and support, and it also has technical support, because sometimes you go with these less famous brands, and they go out of the market, and you don't find the parts to treat the patient, that now they have implants and nobody can restore or replace a screw or an abutment. So I always try to stay with a larger brands, larger company, for different reason. I think is a sophisticated treatment. And one thing it should be like Brånemark used to do, he basically used the traditional Brånemark titanium machine titanium screw. He was selling it very cheap from Brazil. So maybe these companies, they have this super duper high end product. They always have the standard product that is a little bit more convenient. If you want to look at the cost of the material, as far as you make the example of Straumann, if you buy the traditional tissue level with a regular SLA, is like 1/3 the cost of the BLX, for instance.
But to me, it's also interesting. Like you take the some of the biggest dental companies in the world, like Danaher spun off their dental division, and it's called Invista. And if you go to Invistaco.com, I mean, they always have they own Cavo Cur, Noble Biocare, but they also own Implants Direct. So you see these companies, they're kind of like hedge funds. They're kind of hedging their bets. They're saying, on the one hand, we want to sell. I'm sure they would rather just sell Noble Biocare, but they see the value segment, and they own
I want
Implants
to ask you a
Direct.
question. If you want to place an implant in your mouth, which implant you want?
Um, which one would I want? Oh my God! Well, Jerry, the founder of Implants Direct, has been on this show and listened to it. So I know I'm supposed to say Noble Biocare, but Jerry Resnick would get very mad if I didn't say Implants Direct. But which one would you want? Would you go with a Noble Biocare, or would you go with
Actually, I have one, and he's a Noble Biocare. I have it in the mouth for like more than 20 years, and I have 0.5 millimeter bone loss around it, and it's perfect. Screw retain, titanium machine, Noble Biocare.
so you go with Noble Biocare?
Oh, well, I had Noble Biocare, so probably today I will go with Straumann.
Yeah,
Well, with the data out of, if you're familiar with the large paper by Dirk from Sweden,
yeah.
they are you familiar with that? They did a large study on, in Sweden they have the data bank. Everybody that places implant because they're paid by the government have to report. They have like a registry of implant placed. So he went to the registry, look at 10 years of success and failure of all the brands that they use over there, and yeah, Strawman came out with with the highest number.
Can you email me that paper?
Sure.
You said it's a new paper being published.
No, it's not new. It's a few years old.
Oh, it's 2 years old. Yeah, I would love to read that. That is amazing.
But
But
they look at 9,000 implant over 20 years. So.
but I think it's interesting. Like, if you go to Investico.com, and which is Invista, Envista. That's what Danaher spun off. And you look at their deals, like you'll see Noble Biocare, but you won't even see Implants Direct. I mean, they own the company because there's just more margin on these bigger ones. So, I mean, it's.
Oh, well, the other thing is, is costly and everything, but the margin that we put on placing an implant, and for some of us is like 15 minutes work, is kind of very high.
My favorite crown and bridge, though, what I love the most crown bridge is when you're doing a 3-unit bridge and that crown in the middle, you get a bill full price for the crown and you don't have to prep or pack cord. I mean, that is my favorite crown. And then you implant guys want to get rid of that crown, my favorite crown, where I didn't have to do anything. By the way, how they say, you're not supposed to shame people, fat shame people, make jokes about them, whatever. I see a lot of shaming going on in dentistry for anybody that does a 3-unit bridge. I mean, some people say they should be illegal. Some people say that you're a hack.
That is not true. There are indication and contraindication for everything. If I have 2 teeth, they have large restorations, and in between one tooth is missing, there is still justification of doing a 3-unit bridge. If it's well performed, they last the same as an implant. Now, going larger with bridges dual abutment and all those kind of things, no. But the traditional 3-unit bridge is still, even in the front, now somebody's going to have a heart attack. But, I'm coming from Europe, and I had some friends that are like fantastic lab techs, and the quality of the aesthetics in the anterior teeth is amazing. And again, I still think that a 3-unit bridge in the anterior region, if the adjacent abutment needs crown, is still my favorite option, especially when the aesthetic is a challenge. Implants is not an easy aesthetic treatment. It requires a lot of works to develop aesthetic sites.
I'm going to hold your feet to the fire to this answer because, my gosh, when you hear dentists talk about what percent of the population has gum disease and what percent of the implants have gum disease, I mean, the numbers are anywhere. There's people saying that half of America has gum disease, and it's like, really, half? There's 330 million people. Implants, some people say, that at 5 years, 50% of them have gum disease. And what statistics would you say for what percent of Americans or Earthlings, either 8 billion Earthlings or 321 million Americans, what percent of America do you think has gum disease?
Well, as per definition, so if you have two sides with more than with attachment loss in the mouth, non-adjacent side with attachment loss in the mouth, the percentage of periodontitis is for sure up to 50%. If you look at the statistic. Now, we're talking about two sides with attachment loss. Okay, we're not talking about pockets. That's already definition, case definition of periodontitis. When we're looking at a severe disease, so the one that needs the periodontist intervention, then we are looking at way less. We're talking about 8-10%.
Well, that number just got a lot smaller. So you're saying the formal definition of gum disease is two sides of the tooth have a loss of attachment. And based on that definition, it'd be half of America, but only 8% would have periodontal disease?
Severe periodontal disease. Severe periodontitis. If you talk about periodontitis, okay? If you talk about periodontitis, 50% have periodontitis, but about the aggressive form is about 8%.
Okay, well, here's the exact question that she's emailing me a lot is, she sees a patient, they have implants placed 5-10 years ago. It's a bloody perio mess underneath it, and the patient has no pain and can go through the drive-through and eat a Whopper with cheese and loves it. And she's hearing about oral systemic link, and she's like, well, if I'm leaving all this infection, is that getting in his blood, heart, Alzheimer's, whatever? Help her look at this patient in the chair. And when would you factor in oral systemic link and periodontitis and this implant that's asymptomatic that the patient loves needs to actually have something done to it, taken out, replaced, repaired, whatever?
Well, for sure, chronic infection or active infection with pus and implants is different. Peri-implantitis is different than periodontitis because you have the infection penetrate directly the bone, and the presence of this artificial material supports the proliferation of some bacteria that are not present around the periodontal pocket. And you have way more frequent suppuration. And another thing is when you have infection, the pH of the area of the site go lower and increase the amount of release of metal ions in the bloodstream. There are studies that show that patients that have peri-implantitis, they have higher level of titanium metals in their bloodstream, so which is not very good. Titanium is inert and stays with no arm in the body, but only if there's a healthy situation. So going back to the relation with systemic condition and periodontitis, for sure there are situations that get worse in presence of periodontitis and systemic condition that accelerate periodontitis. For instance, if you have a rheumatoid arthritis and periodontitis, your rheumatoid arthritis get more severe. Okay, because you increase the burden of overall systemic inflammation. If, on the other hand, if you have an uncontrolled diabetes, you have a severe sequelae on the periodontal condition. Periodontal disease become more severe with more frequent abscess, rapid bone loss, and so forth and so on. So for sure, the key is controlling the infection. No matter what you do, you control infection, you do good to your patient. And there are different means of doing it. Does not be necessarily surgical. You can get very good result with oral hygiene instruction, non-surgical therapy, combination of systemic antibiotics. Now, there are more and more evidence that the use of systemic antibiotics in combination with non-surgical therapy improve the condition of the mouth. But there's a lot of issues and controversies in the United States because of of course, you want to try to reduce the use of antibiotic, but periodontal disease is a systemic disease, is a systemic infection. And as such should be treated also with the chemotherapeutics device.
When you and I know this is a crazy question, but when you talk about peri-implant mucositis or peri-implant um,
Implantitis.
implantitis, do you put a hyphen between peri-implant or do you make peri-implant one word? Do you do peri?
Yeah, I think it's a hyphen.
You use hyphen. So on this, and do you same thing on peri-implantitis? I mean, is that do you also do a hyphen there, or do you just
Uh,
go
no, I now got me in a soft spot. I think is
but yeah,
peri
because there's
implantitis, I think is a peri implant mucositis. Yeah, I think is peri hyphen. I think, but
so there's peri-implant mucositis,
yeah,
and then there's peri-implantitis,
yeah.
and so do you could you talk about the difference between those two, how you diagnose them or treatment, and which one concerns you a lot, and you know?
Okay, peri-implant mucositis is, as in a case of periodontitis, is the beginning of the inflammatory process. So patients that has um, inflammation around the implant, consistent inflammation of the implant, have a higher chance of evolving versus loss of bones or peri-implantitis. The case definition of peri-implant mucositis is the presence of bleeding upon probing with no bone loss around the implant. And of course, the metrics of defining bone loss, you consider the bone loss when you have radiographic bone remodeling around the implant less than 1.1 millimeter after the first year of function, and no more than 3 millimeter if you look at a cross-sectional assessment. No more than 2 millimeter, I'm sorry, after a cross-sectional assessment. So when there is no bone loss and there is a bleeding on probing, and that is mucositis. The probing depth depends on what is the base position of the implant, so you should have a baseline records on that. But if there is no bone loss, and even if you probe 5-6 millimeter, which is sometimes happen in anterior implants, you can, and there is no bone loss, but there is bleeding on probing, that's mucositis. As soon as you start losing bone, more than 2 millimeter from the platform of the implant, that become peri-implantitis if it's associated with bleeding and suppuration.
And what about you're young? You're a young dentist. You only went to dental school because your mom is a dentist. You're back with your mom. You go to courses, and I think every dental course you go, there's some people in the course a little more excitable than others. But some people still say that periodontal disease is irreversible. Once you lose the bone, you can't grow it back. Other people are saying it's regenerational. You're a bone biology expert with 2 doctorates. Is periodontal disease bone loss irreversible or not?
Not always. There are multiple evidence that you can rebuild the bone, but more than the bone in periodontal disease is important to recreate the periodontal attachment. Bone can remineralize and partially recover or repair, but what you need to have is the new attachment around the tooth. So, but we have evidence, multiple evidence that can be obtained. The problem is how much, what is the level of, and the predictability of achieving that. And then we're gonna go in a more complicated conversation, but the answer is yes, you can regenerate bone, you can regenerate periodontal ligament, you can use different technique and technology from grafting, biologics, combination of grafting and biologics. And the problem is patient selection, defect selection, and surgical technique.
You're it's like listening to Beethoven play the piano. Bone grafting. When I was a little kid and got out of dental school in '87, there was the big miracle drug was Gosh, what was it, BMP, bone morphological protein,
Genetic protein,
and
BMP.
they were doing studies in monkeys, but they I guess in Argentina, and they found out that it was very dose dependent. If you use too much BMP, some of those monkeys were growing other things in their bone. What is bone biology? That was my introduction in '87. What does bone biology look like to you today?
Oh, it's still there's a lot of exciting area of development, and especially in the growth factor department. And BMP is still the uh, one of the best device biologics that lead bone regeneration. The problem is you can only regenerate bone, not ligament, so it doesn't apply to treat periodontal defects. It does apply to treat bone deficiencies in case you want to rebuild um, area for implant purposes. And some case report even show the only situation where you can actually have re-osseointegration of an implant that's been exposed to peri-implantitis by using BMP. One of my good friend, Ulf Vikashow, which is the gurus of BMP, has done most of the preclinical research on that material. And it's still we don't have a specific protocols for that. And as you said, it's dose dependent. We use the dosage that they're using in orthopedics, but it's too much for the application in dental. So the problem now is the cost. As soon as the patent for those medication goes allowed a lower cost, I think we will see more extended use of BMP. And again, another important thing to say about BMP. BMP is not a mutagenic growth factor. It doesn't stimulate cell proliferation. It controls the cell differentiation from the indifferentiated cell to osteoblast. And so that it's not as some of the things that were brought up about BMP is the risk of cancerogenic effect is less than other growth factors. But I'm not a specialist of growth factor. Just say what I know about it.
I had Carl Mish on the show before he passed away, and that podcast didn't sit well with a lot of implantologists who he didn't like his remarks. And Carl, he just tell it like it is. And when he was, in his last few months of life, he really told it like it is. Kind of a brutal deal, but he called when people were drawing blood and spinning it and doing all this stuff. He called that voodoo.
Yeah. I don't mind that. Not for voodoo for bone formation, perhaps yes. There are some interesting data, and we are using this one here too, WVU and all other universities. Instead of using the famous PRP, we're using PRF. And there are some more, data suggesting that the PRF is a little bit more supportive. But the bottom line is what you do with this product is to increase the stability of the blood clot and stimulate proliferation of the cells of the epithelium. So you basically protect your graft much better, okay? And then there's some indication that you keep a lot of nutrients for the cells that kind of boost a little bit the early phase of healing, which is the key. The early phase of healing is the key. After that, everything goes normalized, go to plateau.
There's a lot of kids that are in school, and I'm a big proponent of specialization because it's pretty obvious that in 1900, healthcare was only 1% of the GDP, and in 2000, it was 14% of the GDP. Now it's 2020, it's 17% of the GDP, but in the year 2000, there were no specialties. And then by the end of that century, from 1900 to 2000, the MDs had 58, we had 8, now it's 2020. The dentists are already up to 12. I mean, I just don't see us going back in time where one doctor delivers your baby, amputates your leg, pulls your tooth, and gives you a haircut to boot. But when I look at all the specialties, my gosh, I mean, oral surgery, endopera, you're the grad guru of West Virginia University for the graduate periodontal program. But my God, I look at your program and periodontics. I mean, it's been under more changes and stress in my 32 years than pediatric dentistry or endodontics. I mean, when I got out of school, it was all these neat ways to save the tooth and bifurcations and sectioning teeth. And then I got out in 87. Then about early 90s, people said, you know what? The best periodontal treatment is just throw the damn tooth away and replace it with titanium. And that was magic walk for about 10 years. And everybody started saying, oh, wow, well, we still got periodontal disease. And now I see it going back to just like it was 30 years ago, where now you send a case to the periodontist, you know, he's going to say pull. He's like, you know what, let's do this. I mean, they're going to great lengths to save a human tooth. I mean, it's like it's done a 360. So where are you at right now?
This is what I think. We have periodontal disease is not a tooth-based disease. This is what sometimes people, especially in general dentists, get a little confused. Like, oh, periodontal disease, I say, because you used to look at a single tooth with a decay, the crown, the post, the endo. Periodontal disease is a systemic condition that is the patient that has that condition. And so you have to direct that problem in particular patient. We're going to customize medicine. That's what it is. You have to address the risk factor of the particular patient. You have to implement all the technique to treat that patient. Now, saving or teeth on periodontal patient versus extracting teeth and placing implant. What is better? I got a presentation, a lecture on that if you want to.
I would be honored to have a presentation from you. I mean,
if you look at the literature throughout these 50 years of periodontics, we are proven again that we can maintain dentition in function for very long time. Okay, data show that periodontal therapy can maintain dentition even with severe compromised bone loss for very long time. Of course, you need to implement all the device and the technique, and have a great patient compliance. Now, the question is it better to take the teeth out and place implant instead to implementing the treatment also from a cost standpoint? Study shows that periodontal therapy maintenance is most cost beneficial for the patient, provided the patient maintain that. Now, if I extract the teeth and place implant in a patient that have lost teeth for periodontal disease, do we have the same certainty that those implants stays for a long time in that patient mouth? That depends on the patient age and how much years of service we're going to ask to those implants. So if I have a patient that is aggressive periodontitis, aggressive disease, is losing teeth at the age of 30, if I take all the teeth out and I place implant, if you look at the possibility of having peri-implantitis in this patient is significantly higher. And the bone loss, when you start around an implant, you know that is very fast. So the trick is to use periodontal science to maintain the dentition in a younger individual with severe periodontitis. So yeah, you push back as much as possible the time you're going to replace those teeth with the implants. Vice versa, in an older individual, maybe have more sense to rehabilitate the mouth using implant because the time of service you ask to the implant is less. That's one of the strategy. The problem is we know what to do around a dentition with periodontitis. We don't know what to do around a full arch rehabilitation with peri-implantitis. And you've seen these cases that goes around after 5 years, more than 70% of bone loss around those implants, suppuration everywhere. Patient has spent $50,000 for rehabilitation. Now everything we have to start over again. That is something that every time we approach the full mouth extraction on these patients, we have to think about it. Now, one thing we don't know is, does the removal of teeth change the biofilm on the patient that's susceptible to periodontitis. And is that beneficial? We don't know yet. We have just no data on that information. If that is the case, then makes sense, switching from teeth to implants. But then you have to still control the risk factors to make sure that the treatment is successful in the long term.
Now, I want to be perfectly clear that this next question has nothing to do with me, But now a guy's asked on Dental Town, is it true that treating gum disease and oral health can cure erectile dysfunction?
There's been some data on that. The reduction of the C-reactive CRP and all the pro-inflammatory cytokines that can be produced due to severe infection can have an effect on the overall well-being. Now, do we have, there's some association that individuals with erectile dysfunction have higher periodontitis, but the effect on treatment on ER is unclear.
And again, that was not me. That was I was asking for a friend.
It's always a friend.
I'm just kidding. Another one. One of the biggest debates on Dental Town is this oral systemic link, and so many people believe this oral systemic link, just like on erectile dysfunction. I mean, it sounds pretty obvious to me that if you had a mouthful of perio and pus and infection, you might have some issues. But can you factually say that anything is absolutely the oral systemic link causation, or is it still correlation or yet to be determined, or where are you at with that now?
Well, there are some conditions that have stronger interaction, like as I mentioned earlier, some strong data supporting the fact that if you have a rheumatoid arthritis and periodontal disease, you have more morbidity due to the rheumatoid arthritis. So there is an impact on inflammatory burden that contribute to the pain that you have in your joint or your inflammatory episode and all that. There's a very important study by Francisco D'Aiuto from the Eastman Institute in London that proved that periodontal therapy significantly reduced A1C in diabetic patient, and that is a very well-run study that shows that active periodontal therapy, I'm talking about extraction of hopeless teeth, skin root planing, surgery, removal of pockets, so real, not just scaling a root plane, just real treatment, has a significant impact on A1C value. And remember that a reduction of 0.6 on A1C reverberate on 15 years of life expectancy of a diabetic patient. So that's a lot. And he was able to reduce the A1C up to 0.8. So that's very significant. Then there are some other areas a little bit more unclear, like the interaction between cardiovascular, preterm birth, and they just show association, and that can very well be, but there are a lot of other factors that come into play, and it's difficult to have a clear cut. Other areas that can be that shows correlation, actual the effect of treatment. Because what I think is, okay, if there is a correlation, it means that if I treat the disease, I have an improvement, right? So that is for diabetes. That and the same seems to be also for like chronic kidney disease as well.
Well, I'll tell you what. When I saw that ED article, that I thought that might be a new growth area for dentistry.
Well,
Kyle just threw up. He's had it for the day. My gosh, that was so interesting, and I know we went over
the emerging area for the thing. I'm sorry to interrupt. Is Alzheimer. There's a lot of good results showing that presence of P-gingivalis proteins seems to be involved in Alzheimer degeneration. So we are doing studies here too on that.
Yeah, so my mom is 82, and she's concerned she was losing her memory, and she asked me if I thought she was getting Alzheimer's. So what I did is I just went over to her house and told her I was taking her out for dinner, but I drove her way out in the middle of a farm field and kicked her out of the car and to see if she found her way back home, and she did. So I said, "Okay, Mom, you're good. You found your way back home." So I told
Good.
her once a week I'm just going to drive her out in the middle of the
Screening
farm
test.
field.
Screening
Um,
test.
I got to ask you another question. And I know we went over the hour, or can I go into some overtime, or do you got to get back to
No
class?
problem.
Okay. The digital dentistry and implant dentistry. I mean, there's a lot of old school guys like me who are 58 who say, I just want to use my vinyl polysiloxane. I want to use my Improgum. And but some people are saying that you got to get into the oral scanners, and there's some people that the entire dental implant process is digital from A to Z. Where are you at with the digital implant process? I mean, are you still using rubber base and polypinol siloxane, or is everything a scan to you now?
Well, again, I'm not doing frost here, but I'm involved in I'm the chair of the implant course. We use both. Well, we are doing more and more intraoral scanning and developing more digital workflow. Patient likes it better, and once you get used to it, is a faster process. It's faster to communicate with the lab, and with the CAD CAM machine, you can do most of the work even in your own office.
Well, and then the other question, which I hate to ask you because it's so vague. A lot of people are saying that for treating periodontal disease and all that stuff, that CBCT 3-dimensional is the standard of care, and that the 2D pano is not. Are you what would you think of that statement when someone says you need a CBCT 3D to do perio?
For perio, I think it will be too much. There are some application where you may want to have a small volume CBCT to assess, for instance, if you do amputation or you want to measure furcation or stuff like that, or especially for immediate placement of dental implants. But yet to date, the treatment, the diagnostics for teeth and periodontal conditions is the full mouth PA. There are some issues still with the CBCT scan. There are limitations in detecting the alveolar bone on the buccal aspect, and the interproximal region can be difficult to identify the anatomy. But some study shows that, for instance, if you have to identify furcations and you want to decide if you want to cut the root or emisect the tooth, CBCT scan seems to be the best treatment, the best diagnostic to identify what treatment is best for the patient.
And since you're running the periodontal department, some people are thinking that due to Corona, COVID-19, that the ultrasonic scaler is causing too much aerosols, and that it's time that SRP goes back to hand. What do you think about that?
Well, here for what we do, we try to give we try to give priority to hand instrumentation so that there is less danger to spray around aerosol. That's for sure. The use of aerosol nowadays with the COVID is a problematic. Whether if in your answer there was whether the ultrasonic is better than hand instrumentation for, or worse than hand instrumentation for perio concern, there is no differences. It's just a question of probably fatigue and time. If you use a power-driven instrument, you're faster, but the outcome, if it's done properly, it doesn't show any difference.
My gosh, I could ask you questions for 40 days and 40 nights. I can't. We went over the hour, and I'm my gosh.
I can come back.
No, you can come back. I want to ask you a very controversial question. Crown lengthening. It's like 80% of the dentist haven't done it one time in the last 1, 2, 3, 4 years, and then 20% do it all the time. And then when I go talk to my periodontist friends, they say it's the same. Every periodontist tells me it's like the same 5 or 6 or 7 guys that send them all the crown lengthenings, and then the other ones never even heard of it. I mean, why? First of all, do you see that where in West Virginia it's an 80-20 thing?
Oh yeah, I mean, goes in waves, and it really depends on the evaluation of the restorative dentist. And I have to preach around, because especially sometimes you see some restorative dentists that are still thinking that you don't need crown lengthening, but then you have these students doing making the impression like 5 times to see the margin, and then end out having under contour or over contour margin because the impression is poor. I say, guys, instead of doing this, why you don't send it to us? We're gonna give you a nice soft tissue contour. The tissue is not gonna bleed. You're gonna take the impression with just one layer of retraction cord, and you're fine. And some get the message. It's just a question, of culture, as you said. Some of my colleagues are very good in educating their referrals, and the referrals, they're wise enough to get a nicely prepared mouth for their restoration. And crown lengthening does that. Doesn't mean you have to do it all the time. You have to be able to identify which case needs that. But if you have to force the cord to get the retraction and you still have bleeding, that is where you want to send the patient for crown lengthening. That's my little advice.
Some of the kids get out of school and they go get a job with a DSO, and I'm not slamming DSOs at all. I mean, I think I think competition is good for dentistry, and I know in Phoenix, Arizona, before DSOs, there was nobody open on Saturday or Sunday.
Oh, I'm sorry, my ignorance.
Oh, dental services organization like Aspen or Heartland or
Dental
big
stuff.
corporate dentistry. And big corporate dentistry, they have customers and they create competition. But some of the younger dentists, they go get a job there, and of course insurance, money's the answer. What's the question? And when look at dental radiography. Röntgen came out and invented the x-ray. Thomas Edison looked at it and didn't look at it scared the hell out of him, especially after what happened to Röntgen. So Thomas Edison even walked away from it. But it lingered on and didn't really enter dentistry until after World War II. The Longshoremen's Club started the first dental insurance company in Washington, Oregon, California, turned in later to be Delta. And they covered these x-rays at 100%. And the next day, every dental office was buying an x-ray machine. Well, these DSOs, they see insurance codes where if you put in minoxacycline or doxycycline or perio chips or things like that, there's an insurance code. So a lot of the dentists are being told by an office manager who's not a periodontist or a dentist, and she's a billing, and she says, well, if you're doing root plane and curettage, you need to put a chip in each one of these because I can bill $6, $10, $12 for each one. I wanted to ask you, is that scientifically a good reason, or is that only insurance and a money reason? I mean,
the use of topical antibiotics has an application. It's not like you want to use, but you don't want to use it all the time. You're using those sites that they have already received surgery, and or for some reason you don't want to do surgery, and you want to make sure that the infection is low. You can use it as in a specific cases. Is an alternative to treatment. Is another weapon in our armamentarium. You can use. They are effective, although the impact on attachment gain is like 0.2 millimeter average. But if you look at, say, for instance, you have a patient with a bridge that is fully functional. You cannot do surgery, otherwise you're going to expose the margin, and it's going to be difficult to rebuild the smile. You have to compromise. Those are the sites where, in addition to the manual scaling, you can use this type of technology. There's nothing wrong with that. Using it systematically on everyone just to build them, to me, is unethical, period.
And then I would just ask your office manager, say, Well, minoxidil, doxycycline, what I want to know is, do you recommend that I use hydrogen peroxide or dihydrogen oxide? And if she can't answer that, what's the difference between hydrogen peroxide and dihydrogen oxide?
I don't think, I mean, the materials is available in US is minocycline, which is microcycline is arrestin. The doxycycline gel, I'm not sure it's been approved in the United States. We use it in Europe, but I'm not sure it's available in the United States. We use Arrestin. I should disclose that I'm doing research for them, so just to, it's not that I'm a favor for that, but Arrestin has a good track record in terms of quality. But anything works actually. Pretty much they're all on the same. If I have to decide, instead of going with the perio chips, I'd rather go with the tetracycline type of drug that has more substantivity and is bactericidal at a high concentration. That's what I would do.
My gosh, unbelievable. And then another one, and thanks for staying for overtime. When every time I go to my doctor, he always runs blood tests. And so it makes me wonder, I see all this saliva testing. If dentists are truly the physicians of the mouth, should we be doing more blood testing, saliva testing, things like that? Or are you able to do the same diagnostic exam and treatment plan and success rate without blood work or saliva testing? Do any of these blood tests or saliva tests affect your treatment?
That's been like the quest for the sacred graal for many years in periodontics, to find a marker anywhere in the blood or in the saliva that indicates that your disease is progressing or not. We are not there yet. There are some, these markers goes on and off, and the saliva, the use of those of saliva tester was very interesting. They can map, they can do biomics on that, so proteomics, metabolomics to the saliva. They can even, there are some studies that show that you can even identify risk factor for pancreatic cancer, stuff like that. Regarding our practice, this is what I think we should do as a dentist in general for the sick and our population, of our patients, especially in the US, where diabetes is a very common disease, especially is underdiagnosed. We should use, you should use those A1C tests in the dental office. And when the patient has a severe disease, unexplained periodontal abscesses, that's where you want to run A1C test to see what is the value on that, and eventually recommend the patient to their own physician. We see patients go to dentists more often than going to the physician. And the use of this chair side test especially for A1C value, they're very important.
My doctor says that if your A1C is high, he knows something's wrong, and if he can't find it, he's just going to keep looking and looking and looking. He thinks it's like the MRI CAT scan all rolled into one. Another controversial thing around Phoenix, Arizona. A lot of the doctors, let's say they're I don't know, maybe they're older doctors, but when they see a lot of periodontal teeth, they start splinting with ribbon or orthodontic wires, things like that. And again, it's like crown lengthening. It's like you either do that or you never do that. What do you think about all the guys putting ribbon and ortho wire and splitting all these teeth together that are periodontal infected? Good idea? Not a good idea?
I mean, it's like the occlusion. Okay. The occlusion in periodontitis has been debunked. I know there is group in America where everything is about occlusion and all that. We don't have any evidence or very weak evidence that occlusion alone determine periodontal disease. We know that, and now we want to control, contact that are aberrant and they create excess premitus, excess mobility if we can do it. But that's for the occlusion. I want to talk that earlier, but now give me the chance. Regarding the splinting depends on the patient comfort. Splinting shows that it doesn't improve anything besides the patient comfort. There is no improvement in the ability of the tooth to preserve attachment. There is no improvement in reducing mobility. What you do, you just make the patient more comfortable and you avoid the exfoliation of a tooth. But at that point, the counterpart is when the splinting become sometimes cumbersome to maintain because it breaks and you have difficult for the patient to clean, and it may interfere with a decent occlusion. So there's the pros and cons. We do that once in a while. I'm not a big splinter guy, even because if the patient has a class 3 mobility, I may go for a different route.
Well, it's funny because you started off earlier saying that dentistry, dental implant surgeries, it's a technique. It's not a religion. And a lot of the TMJ guys, it's occlusion guys, it's a religion.
It is.
I mean, you just got to be a believer, and if you raise your hand and start arguing with them, you're not going to have a drinking buddy after the class.
Oh, I know. I've been there. I had that conversation, but again, depends on where you look at it. We have to consider the evidence. We are scientists at the end of the day, and everything is anecdotal. The same as the laser thing.
This is anecdotal evidence. It's no study, but it seemed like when I got out of school in '87, I saw ANUG all the time, and then it's like gone. I mean,
Well, you have to come to West Virginia.
So it's still alive over there?
Oh yeah, smoke, tobacco, stress. There's a lot of factors.
Yeah. My gosh. I could talk to you forever. You're so amazing. Thank you so much. Tell your Greek buddy Photo that I said hi. And I asked him, Howard wanted to know if everybody in that school has to have 2 doctorates, because I only have 1. So I don't think I could ever teach West Virginia. But seriously, Gian Pietro Schincaglia, thank you so much for taking your precious time to come on my show and talk to my homies about all thing perio. Would love to have a course on you. I mean, my gosh, because during the pandemic, online CEs exploded because they don't want to get in an airplane. They don't want to go to a brick building. And that's why the podcast has exploded. I notice, all things virtual are going big. In fact, that's my final question is, West Virginia implementing telemedicine, teledentistry?
Yeah, we actually do. And Poli is organizing that. Yeah, we start doing that. Yep.
All right. All right. Well, thank you so much for coming on the show. I hope you have a wonderful rest of the day.
Thank you for having me, and let me know what we can do if you want to continue this collaboration. I'm very happy to come back.